Hello everyone. Today we will discuss one of the most important practical concept, that is management of blood glucose in hospitalized individuals, mainly in non-ICU care settings. See, the target glucose recommended for non-ICU settings by either ADA as well as British Diabetes Society will be almost from the range of 100 to 180. So just remember this number. Actually, it will apply to both non-ICU as well as ICU patients. So this should be our everyday target when the patient is admitted in hospital. So how to achieve this? Mainly by utilizing insulin therapy we will discuss today. So whenever the blood glucose levels are more than 140, if we are getting this reading, what we have to do? We have to assess whether the patient is able to take orally or not, or if the patient is kept NPO. Majority of the times the admitted individuals will not be having a proper appetite, so they will not be eating adequately. So majority of the individuals will fall into the left-sided flowchart. Otherwise, in general wards or HDU setups, if the individual is adequately taking orally, then we have to follow the flowchart on the right side. Okay. So first we will see what we have to do when we see such common cases of NPO or uncertain oral intake. Here the thing is, mainly we have to utilize basal insulin, long-acting insulin, and the starting dose should be 0.2 to 0.25 units per kg per day. For example, if we take the individual weighing 60 kg body weight, here almost it will be 1/4. So 1/4 will be 15 units per day. This should be the starting dose of basal insulin for this particular individual. And we all know that usually it will be given at 8 p.m. or 10 p.m. in the evening. Then we will be monitoring the blood glucose levels. So this will maintain a baseline glucose level. But whenever required, for example, post meal, if we see any elevation in blood glucose levels, for that we can utilize rapid acting insulin accordingly. So the primary preference is for basal insulin, not for the short or rapid acting insulin. This point is very important. And every day we will be monitoring the individual, and if required, we have to adjust the dosage of basal insulin. For example, if the sugars are not under the target range, then we can increase the dosage by 1 to 2 units daily. Otherwise, if the glucose levels are very well maintained, we can gradually lower the basal insulin again by 1 to 2 units daily till the minimum dosage of 0.1 units per kg per day. This is for those who fits into the left side column. Whereas for those who are taking adequate oral intake, again here we have to calculate daily dosage 0.4 to 0.5 units per kg per day. For example, again for this individual of 60 kg, 0.5 in the sense approximately half. So it will be 30 units per day. But this is not the starting dose of basal insulin. This is the total daily requirement. So now what we have to do? We have to divide it into half. So 15 units will be basal. Other 15 units will be given as bolus. So we know that basal will be given in the evening time, for example 8 or 10 p.m. Then these 15 units we can divide it according to the intake of meals of that particular individual. Suppose the patient is taking lower quantity of meal in the breakfast, so we have to keep the bolus dose lesser in and around the breakfast time, whereas many of the individuals will be having a proper lunch and dinner. So in that case, we can keep quite higher dosage of bolus insulin. And again, as required, if the individual is not maintaining the target glucose, we can adjust the dosage of basal insulin till a maximum level of 0.6 units per kg per day of basal insulin. Till this level, we can utilize the basal insulin to control the glucose. And one more doubt which will come while managing inpatients is what to do if the individual is elderly, for example more than 70 years, because the risks of hypoglycemia will be much more. Otherwise, if the individual is having abnormal renal functions like serum creatinine of more than 2. So in that case, whatever the total daily requirement is there, it will come down to approximately 0.15 units per kg per day. So this has to be remembered. So this is nothing but if the individual is weighing 60 kg and he or she is more than 70 years of age or create value is more than 2. So in this scenario, we have to utilize 0.15 units for that individual's weight. So it will be approximately 9 units per day. So this will be the total daily dosage for that particular individual. Hope you understood the point. Okay, now you have managed this patient with the glucose being maintained in the target range and what to do during the time of discharge. So remember, we will utilize admission HbA1c to adjust the therapy at discharge. For example, during admission, if the individual had HbA1c of about 7%, we have to restart the original therapy. Whatever the individual is taking, we have to restart that. Suppose HbA1c is about 8%. In that case, along with the original therapy, we have to add on some other agent. So, according to the patient's profile, we have to add on the other oral agents, or we can utilize basal insulin. Suppose the initial HbA1c is about 9%, we have to add basal insulin therapy for that particular individual. And for those who are having 10 or more, we have to add basal, or we can utilize Basal-bolus therapy for such individuals. Now we are saying for all these levels, we have to add basal insulin. Now how much dose should be advised during discharge? So that we will discuss it here. Remember, just forget the older criteria. It is being revised. Now, if the HbA1c is less than 8%, then we have to restart the oral therapy, whatever the individual was taking. Better to avoid insulin in these individuals. Suppose the HbA1c during admission was between 8 to 10%, we have to restart whatever the individual was taking. And regarding basal insulin, we have to discharge this particular individual with 50% of the dosage required during hospital stay. For example, if that particular individual was requiring about 20 units of total insulin during hospital stay, we have to make it to 10 units of basal insulin during evening hours. This is for those who have HbA1c in the range of 8 to 10%. Suppose it is more than 10%, here discharge insulin dosage should be approximately 80% of hospital dose. Again, for this individual, it will be approximately 16 units at bedtime. Why we are reducing the dose during discharge is because we are restarting the original therapy which the patient was taking before admission. Hope you have understood the concept. Remember, the target glucose range for inpatient settings will be 100 to 180, and this will apply to ICU as well as non-ICU setups. Then to achieve this particular target, first decide whether the patient is able to take orally adequately or not. As we know, majority of the patients will not be taking adequate oral intake. So in that case, we have to follow the flowchart which I have explained in the left hand side. Mainly we will utilize basal insulin, 1/4 of the body weight units at bedtime, and over that, if required, we will take the help of bolus dosages, and we will alter daily requirement of basal insulin by 1 to 2 units if the patient is not in the target range. A further lower dosage of about 0.15 units per kg will be applied for those who are more than 70 years or if the creatinine is deranged. And during the time of discharge, make sure you will have the initial HbA1c, and based on that, we will advise the individual to get back to the original therapy, and if required, we will add on some other oral agents or insulin therapy. And I have already posted numerous videos regarding how to start insulin therapy and how to store, what all things to instruct for the patients who will be on insulin therapy. All these things are covered. Just check out our channel. You will get all these videos. And if you find this particular video helpful, share it among your friends. Also, subscribe if you have not yet done, so that we can come up with such informative and practically useful videos in upcoming days. Thank you so much.